Hello and welcome everyone. So today we will be discussing about the direct antiglobulin test and the autocontrol. So these are two of the very commonly used tests in the immunohematology laboratory. Whether you can receive a direct antiglobulin test as such for patients or it is a part of the antibody identification workups. So what does direct antiglobulin test mean? So the DAT or the direct antiglobulin test, as it's the short form of it, it detects the in vivo sensitization of the red blood cells, like if there are some IgG antibodies, the complements, or both of them can bind to the red cells while these red cells are in circulation inside the patient's body. So it determines whether the RBCs are coated with these immunoglobulin complements or both the immunoglobulin and complement. So you test the red cells in the laboratory to determine whether these are sensitized or not. So the presence of a positive DAT may or may not be associated with hemolysis. So today we will be showing you how to perform a DAT using a tube technique, using a column agglutination technique. Apart from that, there are various other techniques and the sensitivity of these techniques will be discussed. But the most commonly used ones in the laboratory in our current scenario is the tube technique and the column agglutination technique. So we will also be discussing about the autocontrol, which determines the presence of an autoantibody in the patient's serum. So its role and importance using a tube technique and column agglutination technique as well. So today I have Dr. Soumya with me who will be showing you how to perform these tests, and then we will be having a short FAQ session on the relevance of these tests. Thank you.
Coming to requirements, today we will be performing direct antiglobulin test and auto control for two different patient samples. For that, we will be collecting patient sample in EDTA vials, centrifuge and separate red cells and serum and separate into two separate test tubes. So this is patient 1. Similarly, we have done and taken for patient 2. Next requirement is list. Next, we have taken two clean label test tube labeled as 1% red cell suspension for patient 1 and patient 2. So first we will be performing column agglutination technique. For column agglutination technique, 1% red cell suspension is to be used. So hence, our first step is to prepare 1% red cell suspension. Next, we will be using 1000 microliter and 10 microliter pipettes, normal saline. Today, we are going to use BioRed column agglutination technique gel cards. So, we have now taken the gel cards and labeled as patient 1 and patient 2. So, first for preparing 1% red cell suspension, 1000 microliter of LIS is to be added in the clean label test tube. First we have added for patient 1. Now we are going to add for patient 2. Next, 10 microliter of red cells is to be added in 1000 microliter of LIS to make it as 1% red cell suspension. So for patient 1 we have added. Similarly for patient 2 it is being added now. So now the 1% red cell suspension is ready to use for both the patients. Next, coming to the procedure, 50 microliter of 1% red cell suspension is to be added in the gel cards. So for direct antiglobulin test, only we are going to add only the cells, because only we have to see whether the patient red cells are coated with antibodies. So first we have added for patient 1 and patient 2, and there is no incubation for direct antiglobulin test. After properly balancing, centrifuge the gel cards for 10 minutes. Coming to results, here we can see for patient 1 all the red cells have settled down to the bottom, hence it is negative. For patient 2 the red cells are in the upper half of the gel card, hence it is 4+ positive. Moving on to tube technique. For tube technique, we will be using 3% red cell suspension. So for that, we will be taking 970 microliter of normal saline and 30 microliter of red cells. So first we are taking 970 microliter of normal saline and it is being added into clean label test tube for patient 1 and patient 2. Next take 30 microliter of patient red cells. For patient 1 it is being added into the 970 microliter of normal saline. Similarly for patient 2 30 microliter of red cell is being taken and added into the respective labeled test tubes. Now our 3% red cell suspension is ready. Now moving on to the test. So with the help of 3% red cell suspension, take a clean label test tube for the test and label it as patient 1 and place 1 drop of 3% red cell suspension of patient 1. Similarly for patient 2, take a clean label test tube and label it as patient 2 and drop 3% red cell suspension into the test tube. So now we are going to wash the red cells. Fill 3/4 of the test tube with normal saline and centrifuge it for 3 times. So after properly balancing, we are now going to centrifuge and wash the red cells. So perform this test for 3 times. This is the third wash. So gently decant the saline without disturbing the cell button. Gently tap the remaining saline onto a tissue paper. Now our washed red cells are ready. Now we are going to add AG anti-human globulin. Now we have taken today polyspecific AG and monoclonal anti-C3D. Add 2 drops of AG into both the test tubes. Gently mix the contents. Then centrifuge the tube by proper balancing at 1000 rpm for 1 minute. Take out the test tube from the centrifuge and gently shake the test tube to look for agglutination reaction. Here we can see for patient 1 there is no agglutination reaction at all. For patient 2 here we can see there is 4+ agglutination reaction. So by tube technique also the patient 1 has negative DAT and for patient 2 DAT is 4+ positive. To validate DAT negative results, check cells also known as Coombs control cells which are the IgG sensitized red cells is to be used. So hence we have taken here the check cells and the result which came negative for us is patient 1. We have taken patient 1 and 1 drop of check cell is being added into the test tube. After centrifugation, we can see there is 4+ agglutination reaction which validates our test. Coming to auto control by column agglutination technique. The first and foremost step is to label the gel card column. So first we have labeled for patient 1 and patient 2 50 microliter of 1% red cell suspension is to be added in the wells. So first we have added for patient 1. Next similarly 50 microliter red cell suspension, that is 1% red cell suspension is being added into the patient wells. Next 25 microliter of serum is to be added into the red cell suspension. First we have added for patient 1, similarly add for patient 2. Now incubate the gel card at 37 degrees Celsius for 15 minutes. After incubation, centrifuge by properly balancing the gel card for 10 minutes. So after centrifugation, we can see the result here. For first patient, all the cells have settled down into the bottom. Hence for first patient, the autocontrol is negative. For second patient, we can see the red cells are in the upper half. So for the second patient, the autocontrol is positive, that is 4 plus positive. Now we are going to perform autocontrol using tube technique. For that we have taken two separate clean test tubes for patient 1 and patient 2. Add 1 drop of 3% red cell suspension into the clean label test tube and 2 drops of patient serum. So first we have added 1 drop of 3% red cell suspension and 2 drops of patient serum. Gently mix the contents. Similarly, we are going to do for patient 2, 1 drop of patient red cells and 2 drops of patient serum. Gently mix the contents and centrifuge the tube by properly balancing for 1000 rpm for 1 minute. Now after centrifugation, take out the test tube and gently shake the test tube to look for agglutination reaction. For patient 1, we can see there is no agglutination, and for patient 2, there is 4 plus agglutination reaction. Hence for patient 1, the autocontrol is negative, and for patient 2, the autocontrol is 4 plus positive. Now we are going to perform autocontrol at 37 degrees Celsius. This will help us to know whether there is clinically significant antibodies in the patient. So for this, both the test tubes are kept at incubator set at 37 degrees Celsius for 15 to 30 minutes. Next, centrifuge the tube by proper balancing and look for agglutination reaction. So after centrifugation, here we can see in patient 1, the autocontrol is negative, and in patient 2, the autocontrol is 4 plus positive even at 37 degrees Celsius. So here we can see at 37 degrees Celsius also patient 1 has negative autocontrol and patient 2 has positive autocontrol. Next, coming to AG phase, here we will be adding 2 drops of anti-human globulin reagent into both the test tubes. This will help us to know whether any clinically significant IgG antibodies are present in the patient. So 2 drops of AG is being added into both the test tubes. Gently mix both the test tubes, centrifuge and look for agglutination reaction. After centrifugation, here we can see still the patient 1 has negative autocontrol and patient 2 has 4 plus positive agglutination reaction at AG phase. So at AG phase also patient 1 has negative autocontrol and patient 2 has 4 plus positive autocontrol.
Thank you for the overview. Now coming to the question and answer part or the commonly asked FAQs on these topics. So I'd like to put forward my first question to you. What are the implications of DAT or what are the clinical areas where the DAT is used?
The major clinical applications of direct agglutination test are helpful in evaluation of autoimmune hemolytic anemia, investigation of transfusion reactions, investigation of hemolytic disease of newborn, and evaluation of drug-induced hemolysis, and also it will be helpful in post-transplant hemolysis, especially in ABO mismatched transplants.
Okay, so if a patient or supposedly a blood donor who comes for donating a blood, and after the donation process, when you do the workup, you find that the donor is having a positive DAT. So does it necessarily mean that the donor is having an ongoing hemolysis, or he has a shortened red cell survival?
Thank you for the question, ma'am. A positive DAT does not always indicate hemolysis or shortened RBC interval. Some individuals may have positive DAT without clinical evidence or laboratory evidence of hemolysis. That is, a negative DAT can also be associated with hemolysis, and a positive DAT cannot be also associated with hemolysis.
Okay, so the presence of that does not decide upon if the patient or the donor is having a hemolysis. So we need to look into the additional signs, symptoms, the clinical features, and other laboratory parameters. So coming on to the next question, how does a DAT help differentiate the different types of autoimmune hemolytic anemias? Does it give an insight into what kind of AIHA the patient is having?
Direct agglutination test helps in differentiating different types of autoimmune hemolytic anemia. In warm autoimmune hemolytic anemia, autoantibody reacts with patient RBCs in vivo. So hence, DAT positivity is towards IgG with or without complement. In cold agglutinin syndrome, the cold reactive IgM autoagglutinin binds to RBCs in peripheral circulation, and then this IgM binds to complement as RBC returns to warmer parts of the circulation. So hence IgM dissociates from the RBCs, leaving only the complement binding into the RBC. So in cold agglutinin syndrome, the DAT positivity is towards complement. In paroxysmal cold hemoglobinuria, the IgG autoantibody reacts with the RBCs in colder parts of the body, causes complement to be bound irreversibly to the RBCs, and then elutes at warmer temperature. So hence, in paroxysmal cold hemoglobinuria, the DAT positivity is towards IgG.
Okay, so like every test has some false positive results, some false negative results. So could you elaborate a few of the causes for false positivity in the cases of that?
Yes, ma'am. The major causes of false positive DAT results are if we use dirty glassware, polyagglutinable cells, or if there is in vitro complement attachment, or during the procedure if there is improper washing, improper centrifugation, and if there is any problem with the reagent and the samples.
Okay, so can you enumerate the causes of false negativity in cases of that testing?
Yes, ma'am. The most important causes of false negative DAT results are: first, during washing. If there is any inadequate washing, there will be neutralization of AAG reagent. Second cause is if there is dissociation of loosely bound antibodies during washing. If there is any too vigorous shaking of test tubes, and if the patient has any antibody of low avidity, it usually elutes off during washing. If the patient antibody levels are very low, coated around the RBCs, then there will be false negative DAT results. If the patient has IgA or IgM antibodies, it cannot be detected by DAT because it is not routinely detected by routine AAG methods. And if there is any delay in the reading of the test results, false negative DAT results are common.
So like here we have shown the DAT method using a tube technique and the column agglutination technique. So there are other methods as well. So can you tell me what is the sensitivity in the different methods when you perform a direct antiglobulin test?
Depending on the number of molecules surrounding the red cells, the sensitivity of direct antiglobulin test also varies. In conventional tube technique, it can detect at around 300 to 500 molecules per red cell. In column agglutination technique, it can detect around 120 to 180 molecules. In enzyme linked antiglobulin test, it can detect 80 to 120 molecules per red cells. And in flow cytometry, it can detect even 30 to 40 molecules per red cells.
So once you have a patient with a positive direct antiglobulin test, the next step is to go for elution and see what kind of antibody is attached. So what are the indications or the scenarios wherein you need to do an elution?
Thank you for the question, ma'am. Elution is indicated when there is clinical signs of immune hemolysis are present, serum antibody tests are negative or inconclusive after recent transfusion. Third one is when we are suspecting hemolytic disease of newborn but no maternal allo antibodies are detected. This elution helps in freeing the antibodies from the sensitized RBCs and helps in better detection.
So what is the importance of autocontrol and how do you perform an autocontrol? What insights does an autocontrol provide us into the patient's clinical status?
Autocontrol is a simple serological test in which patient serum is tested against their own red cells to detect the presence of autoantibodies. So basically, it helps in differentiating autoantibodies from alloantibodies and aids in the evaluation of hemolytic anemias. The clinical significance in patients are: first, main primary thing is it helps in differentiating alloantibodies from autoantibodies, helps in the investigation of hemolytic transfusion reaction, majorly used and helpful in the workup of autoimmune hemolytic anemias, and also evaluating pan-agglutination reaction.
So thank you, Dr. Soumya, and thank you everyone for a patient listening. Please drop in your questions in the comment sections below. Thank you.